Kamya, who's going to be talking about the impact of malaria control interventions on malaria burden in the historically high malaria transmission district of Tororo, Uganda.
Greetings to everyone, and thank you very much for coming to this session on malaria elimination. I'm presenting our work on the impact of malaria control interventions on malaria burden in a historically high malaria transmission district of Tororo. This is work that has been ongoing for the last 11 years. So the tools to control malaria are very well known to all of us, using long-lasting insecticide nets, prompt treatment of symptomatic malaria, using ACTs, indoor residual spraying, which is very effective, but unfortunately very expensive, and generally coverage is low. We also have chemo prevention as another intervention that is used. Monthly SP during pregnancy, IPTP, daily TS in HIV-infected and exposed populations, SMC using SP and amodiaquine among children in West Africa, and of course SP is not recommended in areas with perennial transmission, especially when resistance to SP is very high. In addition to all of these chemoprevention measures, dihydroartemisinin in piperacin, which is a long-lasting ACT, is a very attractive chemoprevention agent in areas where SMC is not recommended. Something is wrong with this. So the burden of malaria control. The burden of malaria and control in Uganda is shown here. Historically, we have a very, very high burden of malaria. It's perennial transmission in 95% of the country. The predominant species is P. falciparum, and these are the primary vectors. The control interventions that we use artemether-lumefantrine as first line since 2005. Universal net distributions are done every 3 years. The last one was just completed early this year. And then IRS, which has been re-implemented since 2006 after many decades. So currently, IRS is implemented in 15 out of 121 districts. And we have seen some significant decline in malaria burden, as shown on the right here from the Malaria Atlas project. You can see a decline in parasite rates and a decline in incidence of malaria. So there's something wrong with this. So understanding the impact of malaria control interventions is critical to guide strategies for malaria control in hyperendemic areas. Most of the studies that have been presented before this one are really from low endemic areas, but in hyperendemic areas, control of malaria is different. So over an 11-year period, we have been measuring the impact of malaria control interventions in cohorts of children enrolled in 3 clinical trials and 2 observational studies. This area that we are working in is historically whole endemic with an EIR of 310 infectious bites in 2011-2012. And the burden of disease is highest in children 5 years and under. Interventions included, some were individual interventions that are going on in this area. Some are individual that are given by our studies, and some are population-level interventions, including LLIN distribution, like I said, and then repeated rounds of IRS. So these are the studies that I'm going to talk about. We started working in this area in 2007 with this TCC, which is the Tororo Child Cohort. So in there, we have 98 children. And then this is another study that we did. We call it P3, which is Project 3, which is, we randomized patients to receive these chemoprevention regimens. And again, the numbers are here and the person years of observation. Another study that I would describe is the PRISM one, which is, here we don't have any chemoprevention going on. And as you can see, some kids in this pre-IRS era, and then others in the post-IRS. And then another study called the Birth Cohort 1, where we gave DP every 12 weeks and DP every 4 weeks, and then PRISM 2. So those are like the studies that we have been doing in this area. Of course, So this is using a standardized methodology. This is the methodology that we have used. All cohort participants are given an LLI at enrollment, and the universal net distribution is given at district level. IRS has been implemented since 2014 using Bendiocab every 6 months for the first 1 to 3 rounds, and then Acteric every 12 months for the 4th and to 6th rounds. We provide free care at a dedicated clinic 7 days a week, and parents are encouraged to come to this clinic. We reimburse transport and then do blood smears on every child who comes. If it is positive, we treat with AL. If it is complicated malaria, we treat with quinine or artesunate. Routine evaluations are done every 1 to 3 months. We did BS for microscopy for all studies except the TCC. The TCC with the total child cohort. And then we also did detection of microscopic parasitemia using a lamp, and we do asymptomatic parasitemia is not treated. So we've got some kind of standard methodology for all of these studies so that, it is comparable, as I will show. So this is the location of where we are doing the work from. This is Africa, and then this is Uganda. You can see in eastern part of the region. And as you can see here, this is where the patients are coming from. As you can see here, there's a lot of overlap. I mean, we are really like just having a cohort of people coming from the same area. Oh my God. Yeah. So these are the statistical methods that we used: pooled analysis, using data from all the studies, and using generalized linear mixed effects model. We adjusted for study chemoprevention group and age, as well as individual clustering. Our outcomes were incidence of malaria, prevalence of microscopic parasitemia, and prevalence of microscopic plus submicroscopic parasitemia. The reference group that we used are arms, study arms receiving no chemoprevention in the pre-IRS time. Oh, did I? So this is, I hope I can walk you into this graph. Yeah, the incidence, this is a graph showing the incidence of malaria. Now on the left, here, as you can see, these are the different chemoprevention arms. These ones, the different colors are showing the different chemoprevention arms. And then the symbols inside there, they show the individual studies. For example, in the pre-IRS era, you can see the rates of malaria there. And then, as I'm going to show on this side, you'll see the numbers, the incidence of malaria. And then here, I hope you can see the vertical lines here. They show the different, intervention measures. Most of these are rounds of IRS, and then universal net distribution in this color. I hope it is clear to you out there. So these are the interventions. So this is pre-IRS, and then this is post-IRS. So maybe let's concentrate on this side of the slide. As you can see, before anything was done, kids between 0.5 and 2 years, these were the kids that we were looking at. 0.5 to 2 years, and without HIV. So those kids were getting 5 episodes of malaria per year. It's really coming back to the clinic every 2 months. The child is coming to the clinic. And then we did our first study that involved these chemoprevention arms. As you can see, we tested TS, SP, and monthly DP, and you can see that some of them really did nothing. They were like placebos. But as you can see, monthly DP reduced malaria risk by about 50% compared to the reference. Now, this is the pre-IRS period, this one. Now, after IRS, you can see when we started to give IRS, we divided it into 1 to 4 rounds and then 5 to 6. So when there were fewer rounds of IRS, the incidence was 0.38. And as you can see, in our chemoprevention arms, giving DP every 12 weeks or give DP every 4 weeks, you can see giving DP every 4 weeks reduced the incidence of malaria significantly compared to not giving it at all. Now remember, all kids were getting IRS in this, at this time. But as you can see, as you increase the rounds of IRS, the difference between, the additional effect of giving DP is not as impressive as when you give DP in the context of fewer rounds of IRS. Now this is showing microscopic parasitemia, and again I'll go straight to this side of the slide. As you can see, this is the reference 6.4, and you can see the prevalence of parasitemia. But let me draw your attention to using monthly DP, again without IRS. As you can see, compared to no DP, you can see the drastic decline of prevalence of parasitemia when monthly DP is given. And then during IRS period, again, when you have few rounds of IRS, you've got 0.5% prevalence. And when you give DP every 4 weeks, you bring it to almost 0. And of course, as I said before, with more rounds of IRS, you begin to lose the additional benefit of DP every 4 weeks. This is a slide showing the other outcome that we looked at, which is microscopic and submicroscopic parasitemia. Now, you can see this is dark. It's because early on we were not doing any PCR, to identify parasites. Again, I'll draw your attention to the reference of 35%, and then during the IRS era, you can see, the drastic declines of microscopic plus submicroscopic parasitemia in the context of IRS. So in summary, what are we seeing? We are seeing that monthly DP significantly reduces the incidence of malaria and the prevalence of parasitemia, even in the absence of IRS. Monthly DP reduces the prevalence of microscopic and submicroscopic parasitemia in the context of few rounds of IRS. And in this area, which has historically very high burden of malaria, just as I said, 310 infectious bites, you can eliminate malaria with multiple rounds of IRS, chemoprevention, and LLIN. We are almost seeing no malaria at all in this area. So IRS is very effective but expensive. Currently, we are using it only in 15 districts. So much work is needed to translate these findings into policy, how to sustain them, but definitely we have reduced malaria to almost 0 using these different interventions. I would like to acknowledge so many people. Some of them are in the room. My colleague Grant Dozy somewhere there. He's doing like that. and many others who are written here. And these our partners, funders, and collaborators who are on that slide. Thank you very much. And that is the end of my talk.
there's a short question. Go ahead.
Hi, I'm Tom Kesterman from Fondation Mérieux. I have a very burning question. You always refer to the pre-IRS and post-IRS era in this site, but this exactly corresponds to the pre-LLIN and post-LLIN eras. So you seem to attribute the effect to IRS, which is very possible, but how do you disentangle the effect of LLIN's distribution and IRS in your study?
Yeah, of course, I have not shown all the data, and I have not gone through all the details. Yeah, we see some modest effects of LLINs, even without IRS. But certainly when IRS is implemented, you know, the drastic declines in malaria. So I think it's really a combined effects of LLIN and IRS, and you cannot completely separate it apart. But where we have done so, you know, we've seen, you know, IRS has greater impact than LLIN. I'm not saying that LLIN do not have any impact, but I didn't go into all of the details to show, you know, the different effects of the separate interventions.
Okay, thank you, Moses.